Right. Hello, everyone, and good afternoon, good morning, or good evening, depending on when you are joining us or when you're listening to this on demand. My name's Ahmed Elsharkawy. Welcome to the EASL Studio, your weekly hepatology broadcast news. Today, I'm delighted to be joined by a great faculty to discuss the subject of hepatitis C and the idea of the continuum in patients who are undergoing or who are participating in high-risk practices. And I'm joined by a great faculty, by Tatyana Kushner from New York, by Sabela from Barcelona, and by Ashley Brown from London. And it's great to see you all. Thank you very much for joining. And I'd like to start off, if I may, by asking you all whether you see these kind of patients, and I maybe by way of introduction, kind of patients I'm talking about are often people who we pick up in drug and alcohol services, might be picked up as viraemic on dry blood spot testing or on Kefiad real point of practice testing, point of care testing, who we then treat, but we never get back for an SVR, and then often they re-engage with services a few months, even a couple of years later, or are picked up by ED testing, emergency department testing. Ashley will come back to that. And they're viremic again. And we always are left thinking, was this a failure of treatment? Was this much more likely to be a failure of adherence to treatment, or have they reinfected themselves? So I suppose let me start by asking you, Tatyana, do you recognize this kind of patient? Do you see them quite often in your practice or not?
Yeah, these are patients that we still see in our practice, and it's a bit of a complicated question because you want to understand what truly happened with their treatment, but many times you don't have the data points that you wish that you had to know, did they complete their treatment? Even if they did say that they thought they completed the treatment, were they fully adherent during their time? Did they take more than half at least of their DAAs that were prescribed? And then finally, did they have follow-up? Did they present for their SVR12 check at all or not? And perhaps even if they didn't present for their SVR12, was there any blood work earlier? Perhaps was there an SVR4 check and then they became lost to follow-up? And then, of course, you really need to take into account the history that they provide in terms of their ongoing risk behavior and if perhaps they're at risk for reinfection as well. One helpful tool, of course, that we do have that's pretty simple is genotype. So if you had an initial genotype and then now they come to you and you can check a genotype, and if they're different, that is a very helpful clue to tell you that perhaps this is much more likely a reinfection. But if the genotype is the same, then I think you're still left with questions.
Great. So I think that's great what you've said, because that introduces a lot of the themes that we want to discuss and sort of really explore in this episode. So Sabela, what percentage of your Hep C new patients or new prescriptions, shall we say, do you think fall in this category?
Actually, a significant proportion, to be honest, because we started a patient-centered circuit in 2018, where we, took the diagnosis and treatment out of the hospital to harm reduction centers. So most of the treatment prescriptions that we are starting every week come actually from these patients, either because it's a new diagnosis or it's a reinfection, which is something that we see very often. In this kind of patients. We moved to a very difficult setting where we didn't have the possibility of having a blood test available. So we used point of care testing and DBS. And as Tatyana was saying, sometimes it was very difficult for us as well to assess whether it was an failure to treatment or a reinfection, because it happened exactly at around SVR12 time point with the same genotype very often. So DBS was a useful tool in our case to, extract RNA and be able to phylogenetic analysis and really see what was going on there. And to be honest, from our experience so far, most of them were reinfections, not failure to antiviral therapies, even though adherence is not perfect, as we see in our general population that come to our outpatient clinics. Reinfection is our main issue so far. Yeah.
Interesting. So actually, with your hat on as the director of NHS England's Hep C program, I'd like you to reflect both on your own practice and sort of on the wider England practice, if you like. And I mean, I think I agree with Sabela and Tatyana. I think those are the majority of the patients that we're seeing now. What are your reflections on that specifically?
Yeah, I mean, I agree completely. I think as we progress towards elimination, that the patients that are left are often the most difficult to engage and get through treatment. And certainly we still see those in our drug treatment services. The other group that I think we should talk about as well, certainly here in Western Europe, is the migrant and the asylum seeking population, because again, often these are moved around by services. So we may have seen them at one touch point, but we don't know where they're going to be moved to next week, next month, or in 6 months' time when we're looking for those SVRs. So yes, it is partly the community of the homeless, of people who use drugs, but let's not also forget those migrant populations and asylum seekers, where we have exactly the same problems. We see them, we give them the full course of treatment, but we don't know where they are in order to find out the outcomes. And in all of the chaos, sometimes those medications have been lost, they forgot to take them, whatever it might be. So we're talking about a group of patients where outcomes are perhaps more difficult to track down. And to differentiate that, as you've highlighted, is it adherence? Is it reinfection? Is it drug resistance? And getting through those is going to be difficult. Just to one of your points, Tatyana, I'm also a little bit cautious, even when it's a different genotype, because we've certainly seen cases where patients have, particularly patients who've used drugs for many years and may have been exposed to multiple genotypes. So they've actually got a combination. Our labs often report the dominant genotype, and sometimes one course of treatment might clear the dominant, but allow the second genotype to grow up. So it may look like a new genotype, but in fact, it may have been a suboptimal treatment regimen.
And I suppose that's mainly the case, Ashley, when we're using genotype-specific treatment.
Yeah.
Out of interest, and we're encouraged in England to use genotype-specific treatments, Sabela and Tatyana, in your situation, are you using much more pan-genotypic therapies in this population, or are you still trying to target genotype if you've got that data?
No,
Who wants to
actually,
go first? Sabela, go first, please.
yeah, sorry. Yeah, in Spain, is pan-genotypic regimens are the first line, regardless genotype. And actually, when moving to these microelimination programs, it's just the positive viremia that you need to start treatment without anything else. I mean, it was really a game change for pathologists that were used, to have this in this academic environment, to have all the available data with all the liver disease stage as well. And now moving on, just a positive viremia is enough to start treatment. Pan-genotypic regimens are the first line in our
Yeah, and it's been a big change in a very relatively short period of time, hasn't it? Tatyana, do you, how about your practice where you work?
Yeah, very much I agree. In the US and per our guidance, it's very much emphasized to use pan-genotypic regimens. And even if you were to try to use genotype-specific regimens, some of the insurance companies may actually not approve it, or it may not be on their formulary as a preferred agent. So very much we recommend using pan-genotypic regimens.
Okay, that's interesting. So one of the tools we've got is to use pan-genotypic versus genotype-specific. What other tools have we got to try and improve adherence the first time around before we come to talking about labeling? So, Sabela, how else are you trying to encourage the patient to take the full course of treatment?
So when moving on to vulnerable populations, which are the most difficult people to engage into adherence because they have other issues that might be more important even than hepatitis C, we do try, to get into their healthcare system. So for example, if they are receiving opioid substitutes therapy, that's a way of, ensuring adherence, because at the same time that you provide the methadone, you can also provide the DAA therapy. And we have been trying to adapt to the people needs. So if they come every week or they come every month, that will be the timing that we kind of ensure and we encourage to keep on antiviral therapy for hepatitis C. So I think that we really need to individualize and to create a circuit that is useful for the population that we are addressing at the moment.
And Tatyana, what other strategies do you use?
Yeah, well, I think it's very interesting because in the US and per the AASLD, there's really a big emphasis on simplified treatment approach, which really emphasizes less touch points, less testing, and a simplified course of treatment and follow-up, which implies less contact with the patient. But in reality, I think what is most helpful, and I agree with Sabela, is frequent touch points. So care navigation programs where you have specific either peer navigators or other care navigators that have frequent interaction with the patients throughout their course of treatment, and then, leading up to SVR12, as well as more frequent visits, I think is really needed in certain patients. Of course, there are some patients who are very reliable and the simplified approach works very well. But in others who